Hello, good evening. Very warm welcome to everyone joining. This is our virtual information evening, Paths to Parenthood. I'm Alison Campbell, I'm your host tonight. I'm Fertility's Chief Scientific Officer. I'm standing in for Dr. Amy Barry, who normally does these sessions. So just to let you know what you can expect from this evening, we're going to talk for about 40 minutes. We've got, it's quite interactive. We can answer your questions live as we go. We've got 3 short information videos all about care fertility and our wonderful team. And we're going to go through, really walk you through right from initial consultation through to embryo transfer. Lots of diagrams and information, photos and videos. And then we're going to intersperse this session with 2 Q&A sessions with myself and Professor Charles Kingsland. So you can ask questions in the private questions tab, or else you can use the chat function so everyone can see the questions. Entirely up to you. You can also send questions through email to events@carefertility.com. So if we don't have time to answer all the questions live during this event, then we'll get back to you via email. And I'm pleased to say we've got our new patient inquiry team are available as well, so they should be able to help as we go along. We've got a phone number for them, it's 0800 564 2270. So I'm going to start with a short introductory video. I've got to drive this all by myself, but I've done it before, a little bit rusty, but here we go. I'll just give you a short video and come back to you.
Family. It's who we are and who we're always going to be. It's the important little moments, the big emotions, the beating heart at the centre of our world. It's the journey that we take there, together, one step at a time. Family is the one thing we'll always care about the most, because we believe that family is for everyone. And through our care, we'll do everything we can to make your dream real. We don't just care, we are care.
My name is Professor Charles Kingsland, and I'm the Group Clinical Director for Care Fertility. At Care, our number one belief is family for everyone, and this means we do everything possible to help everyone start or grow their family. We know that nothing is as important as family, and that's why we care so much about wanting to give every patient that comes to us their best chance of having a baby. Of course, families come in all shapes and sizes. We get heterosexual couples, couples of the same sex, we get single patients wanting to start a family, we get NHS patients. When you have a fertility problem, there should be facilities available for you to get the best advice and the best treatment readily available to give you the best chance of having a baby at a time in your life that is best for you. We will use all our knowledge and experience combined with highly individualized treatment, personal treatment, to help you have the family you are longing for.
Unbeknown to Gemma and I, we both carry a gene, a deafness gene. We actually have a daughter who was 3, but who was born prematurely deaf. And we were given the option and chose to go down a fertility treatment to kind of avoid our second child having that same gene.
We were very lucky in the fact that the clinic was only down the road from us. So we felt there was one around the corner. It had good reviews. We just felt it was good for us, didn't we?
The whole package made us just feel really comfortable that actually going with Care was the right decision.
So the team that we worked with at Care were unbelievable. They were caring, they were sensitive, they were compassionate, empathetic. And even when I was ringing out with I was feeling pains down one side, that the reassurance that they gave me, they honestly do hold your hand every single step of the way, and I feel like they lived the journey with us.
So I've had several treatments with Care, I now have a baby, and that's taken a number of treatments, fertility treatments, different alternatives, different medicines to try and get it to work for me. I have always said I would recommend Care Fertility. I would recommend them for the comfort factor that I received, the friendliness, and just I think the word is my faith in Care Fertility.
Okay, so I'll come back now to with the presentation. So we're going to go through the journey. Not sure why I'm echoing a little bit here. Right, so family is for everyone. Around 1 in 6 people need help starting a family. And at Care, we believe that family is for everyone, and it's one of our slogans because we feel so passionately about it. So during this event, we're going to mainly focus on the general IVF process. But whether you have treatment with your own eggs, your own partner's sperm, or the help of a donor, the principles of what I'm going to talk to you about are generally the same. Next slide. Let me do this. Right. So we've got fertility clinics across the UK and also in Dublin, and lots of satellite centres around which feed into them. And so with this arrangement, all our patients get the benefit and the knowledge pulled from a huge team of specialists, of fertility scientists, nurses and medics across the whole of the map there. And here we have Shah. It's really easy to get started with treatment at Care. Shah's from our new patient inquiry team, and they're very friendly, knowledgeable, and they're here to answer all your questions. So we've got people on the phones till 8 o'clock this evening if you need their support. So this is Alex, she's our laboratory manager in our London clinic, and getting the diagnosis right from the start and gathering information from you when you come to see us for the first time, it's really important so that we can give you the best advice. And we've got a secure online patient portal, which is where all the information related to your treatment is held in one place. So if you've had treatment before somewhere else, then you can send this information through into your portal, so we've got access to that. And it's all reviewed by one of our friendly consultants. This is George in our Sheffield clinic, and he's able to help you, like all our other medics, to review your information and give you the best possible consultation they can. I'm just going to check that everyone's all right with this. Yeah, the sound's a bit distorted. I'm not entirely sure why it sounds not great, but we'll carry on. Let's try and start because it was when I jumped from one to the other. I don't know if I've got an echo going on. I'll just try a different process. Hold on, let's shut that down for a moment. It's still a bit echoing. All right, we're going to go back to the slides. Sorry about this. Okay, might be a bit better. So the IVF process. Right, so once you've had your consultation and we have all the information that we've got, we've probably done a semen analysis, an ultrasound scan, we've got blood test results, and we've made a plan for your treatment. And all of this information goes to your portal so you can access it at any time. We'll send additional information to help you follow the course of the process and with all instructions, as well as direct support from the nursing team usually back at the clinic. So everyone's treatments are going to be different, and we actually pride ourselves in making sure that we individualise patient treatments. So our treatments range from very simple intra-uterine insemination, where the sperm will be put into the uterus after preparation, through right through to very technologically advanced treatments, much more complex treatments. But I'm going to spend a few minutes just walking you through the key stages of any IVF treatment. We start with ovarian stimulation. So this slide shows the egg collection, and the ovarian stimulation is a very important process where the doctor will prescribe the medication that they think is best for you. You follow the protocol and you'll take the injections on a regular basis, and this will be stimulating the ovaries so that we can collect more eggs than would normally be produced in a natural menstrual cycle. And this is Di, she's one of the nurses originally from our Cambridge Work Clinic. And she's just demonstrating here how the nurses spend time with you explaining the medication protocol and teaching you how to do self-injections. So it's very important that you know exactly how to do this, and we keep it very simple. It's not complicated, it's not painful, but it's very essential to the IVF treatment process. This is Rima, one of our medics, the medical director in our Birmingham clinic. And the next stage after you've been undergoing the ovarian stimulation to get the ovaries developing more eggs is the monitoring. So it's very important that we see how the eggs are developing in your follicles on your ovaries. So we monitor the development of these follicles using ultrasound scans, and the monitoring phase is usually lasts between 5 to 7 days. We'll tell you when we need to see you in the clinic, usually in the morning, where we can do this ultrasound scan and assess how those follicles are developing on the ovary. When we're happy and we think the follicles are sufficiently ready, then we'll give you a trigger injection, and this will help the maturation of the eggs, because when we collect them, we want to be in the right condition and ready to meet the sperm to try and get the fertilization. So once you've had the trigger injection, we'll give you time to come into the clinic for the egg recovery, the egg collection. It's a very straightforward procedure, and we use ultrasound guidance to send a fine needle to the follicles to aspirate the fluid and the eggs within them. It generally takes about 20 to 30 minutes, and it's usually then followed by a short rest. So just to make sure you're feeling okay before you go home. So it's a day case. If you're using donor eggs, then we usually thaw them around the time that the sperm is being produced and prepared. And speaking of sperm, we have a little video, I think, to show you here. There we go. So you can see here the sperm swimming on the screen. So sperm, it may have been previously frozen, it may have been surgically recovered, may be produced by ejaculation, but the embryologist in the lab will assess the sperm and prepare it so that it's ready to meet the eggs when they've been collected, and then they're ready to be fertilized. Let me close this one. We'll go back to the presentation. Lots of things to show you tonight. Here we go. So the IVF process is a very important step, as they all are, but this is when we mix the eggs and sperm. So the eggs have been prepared and collected, they've been matured after the ovarian stimulation, the sperm's been produced or retrieved or thawed, and it's been washed and prepared, ready to meet the eggs. So there are two ways in which we can try to achieve fertilization in our IVF laboratories. The first one is called IVF, conventional in vitro fertilization. So this is where we just mix the eggs and the sperm. We make sure the concentration of sperm is optimal. So we may dilute it with a special culture medium, a fluid that it likes to be in. And then we mix the eggs and sperm in a little petri dish. So it's quite straightforward, just got to be optimal. Of course, the conditions in our incubators have to be perfect, the temperature, the gas mix, so that the fertilization chances are maximized. The second way that we can achieve fertilization is by ICSI, that means intracytoplasmic sperm injection. So this is Lena, one of our lovely embryologists in Nottingham, sat at the micromanipulator. So this is the specialised equipment where the embryologist will use two pipettes to inject a single sperm into the middle of a mature egg. So we generally use ICSI rather than IVF when the sperm numbers aren't sufficient to allow IVF to take place, or if the patients have been had treatments before with a poor or a failed fertilisation with conventional IVF. They're generally the main reasons that we would do ICSI. So the next stage after we've done the IVF or the ICSI to bring the eggs and sperm together is the important fertilization assessment. So the day after the egg collection and that day when we do the insemination, we look down our specialised microscopes to see if there is signs of fertilisation. And following the confirmation of that, and of course all the patients will be informed as soon as we know the good news, and then the embryos are left mostly undisturbed for several days in our specialised culture medium in incubators. And they have uniquely identifiable RFID tags, so everything is very carefully labelled with the highest technology to enable us to follow the track of the sperm and the eggs and the embryos right through our IVF facilities and labs. And we aim to transfer embryos at the blastocyst stage. I know there's lots of words and some of you may not have heard of them, but I guess many of you will have been reading around and may have gathered some information already. But the blastocyst stage is the stage of embryo development. You can see on this slide here, the bottom right-hand corner, those 4 images, that's the blastocyst stage. And it's the optimal stage to transfer embryos, and we get the best results when we do that. So that's what we're aiming to do. We don't manage to do that for every single patient, but the vast majority will have a blastocyst transfer. So just going back to these 4 little images in black and white, the one in the top left is the signs of fertilization. You can see 2 small pronuclei. If you're looking on your phones, you may not see them, they'll be small, but it's the most wonderful sight for an embryologist to see these 2 nuclei which signify a normal fertilization. We've got a nucleus from the egg and one from the sperm, and that's the fertilization that we want to see. And following on from that, the next image, we can see 4 cells in the embryo, and then at 64 hours approximately, we'd expect to see about 8 cells. And then the next couple of days after that, so day 4 and day 5, we start to see the blastocyst developing. So how do we choose which blastocyst or which embryo to transfer? And I think this is where Care Fertility particularly excels. We've done a huge amount of work in this area, and most patients are fortunate because of that ovarian stimulation that we spoke about. They are fortunate to have several embryos, and it's a really important decision when we're looking down our microscopes to decide which embryo we should choose for transfer. And which embryos we may freeze for future chances and future pregnancies, hopefully. So Care Maps is something that's quite unique to Care. It's our algorithm that we've developed using our time-lapse incubators to predict which embryo, based on its behaviour, is most likely to result in a baby. So we've developed in-house algorithms from a decade of data and evidence. So we're very proud of this work, and we've been sharing it and publishing it for many years. So it's one of the tools that we use, a non-invasive tool to assess the embryos and give us a chance of live birth, which we can share with our patients. The other specialised method for selecting embryos is called Pgta. So the picture on the right of the slide here is embryo biopsy. So you might be able to work out that that's the blastocyst again, and we're using micropipettes, similar but not quite the same as we used for ICSI when we put the sperm into the egg, and just to take a few cells from the embryo. It has more than 100, so it can spare a few cells. And for some patients, This is a really important and effective treatment because we'll take a few of these cells and we'll send them off for testing. And what we're looking for in this genetics lab is that the number of chromosomes, the copy number, is optimal, it's normal. Because particularly as women get older, their chance of having incorrect copy numbers of chromosomes in their embryo increases quite substantially. So if we can see which embryos have the right number of chromosomes, then we choose those embryos for transfer, and this gives us the best chance of a pregnancy. So the next step will be embryo transfer. So irrespective of how we've chosen your embryo, whether we've used care maps, standard methods, which is just morphology, it's the shape of the embryo, the number of cells, or whether we've used Pgta, we do the embryo transfer in exactly the same way. So the embryologist, after choosing the best one, loads the embryo into a very soft catheter. It's not dissimilar to a piece of spaghetti. It's soft, it bends, so we use that attached to a spine syringe to take up the chosen embryo, pass it with the medic or the nurse in the procedure room to transfer it into the uterus. It takes about 10 to 15 minutes to do this, and you can go on with normal activities after that. Then we have the 2-week wait, so it takes, there's the embryo transfer, not dissimilar to a SNU in terms of the position you need to be in, but the 2-week wait is, what you need to do then is go home, relax, and wait until the date we give you to do the pregnancy test. If it's positive, then you come back to the clinic for a scan a few weeks later. We're looking for a heartbeat. If it's negative, then we will offer some support, of course, and counselling is available if you need that. We'll also arrange a follow-up appointment if there's been a negative test to talk about the next steps if you want to discuss further treatment or different options. So moving on to donation. So we have a very large team of donation and counselling specialists at Care. So we have everything in place if you need to use donor eggs, donor sperm or donor embryos. So our donation team has over 25 years of experience and have helped more people start a family with a donor than any other clinic in the country. So we support you through the entire process. And we talk about donation later on if any particular questions come through. So lots of support. I think I've already discussed this probably enough, but just to say that we have lots of different ways that we can support you. Everybody's different. Some people want to have a virtual support system, others want the phone. We have a buddy program, so if you want, we can link patients up with other patients who are going through a similar treatment at a similar time. So for that sort of peer-to-peer support, we have a forum that patients can go on to, ask questions and read what's been going on in the past with lots of information resources there. So endless types of support. We also were doing, I think they're probably restarting it, if not soon, they may have already a walk and talk session so that staff and patients can go walking together and meet up to support each other through the process. We're here to support you not just medically but emotionally and financially as well. We have Care Pay, which is an individually tailored IVF funding package. So we've designed this ourselves just to take the financial or give you financial peace of mind, really, knowing that the plan's in place to fund treatment if it's already not funded by the NHS. We've created this Care Pay following feedback from patients, so it's managed entirely in-house. So our patients have this more seamless experience with their treatment. It's more personal and more private since we introduced this scheme. There are 3 programs, and they all include, for the cost, the cycle monitoring, the egg collection, all the embryology, including the care maps, which was the time-lapse algorithms that we've developed, the embryo transfers included in that, and embryo freezing and storage, and then unlimited embryo transfers from those fresh and frozen embryos. So we're going to just move now on to our first Q&A session of the event. So a reminder again that we have our new patient inquiry team available until 8 o'clock if you want to talk to them. You've also got the chat function and questions tab, or the email events@carefertility.com. So I shall close this down, and hopefully by magic our Professor Charles Kingsland will pop up and will answer some of the questions that have been sent in. Hi Charles, are you there? Hopefully he'll arrive in a second. We're going to do 2 sessions of questions and answers with Charles Kingsland. He's a mind of information, and he should be here shortly. There are loads of questions coming in, so I can get started if he doesn't appear to. Right. Loads of questions. Right, well, I can start with the first questions. Right, one of the embryology type questions I can start with is, can you explain the lab processes for embryos of patients who haven't used care maps versus those that have used care maps? Okay, so it's a really good question. So in our laboratories, we have specialised time-lapse incubators, and we have specialised flatbed incubators, which don't have the time-lapse facility. Now, here we are. Welcome, Charles.
Sorry I'm a bit late. Can you hear me?
Yep, we can hear you. I was just answering a question. So you just relax while I answer this question, and then we'll fire some at you because we've got loads. Just talking about the difference between what happens in the lab when it's care maps or standard incubators. So it's basically the incubator that's quite different with the 2 offerings. So care maps is photographing the embryo through multiple focal planes every 5 to 10 minutes, and then we apply an algorithm to predict which embryo will give the best chance of a baby based on our historical massive data and the time that the embryo has reached all of these developmental stages. This, compared to the standard method, which is used across the world very successfully and also in our laboratories, is we'll check the embryos for fertilization, as we saw before, and then we'll put them into these flatbed incubators and we'll leave them. We don't disturb them. We have confidence in our assessment of the blastocyst on day 4 or 5 to choose the best one that we can, even without all of that time-lapse information. That adds much more complex information and a sophisticated algorithm. If we don't use that, then we'll use the shape and the form of the embryos, the blastocyst, to choose the best one. So the culture medium is the same, the incubation environments are the same, but the key difference is the information that we're getting from the time lapse. And that's the main difference between, to answer that question about the lab processes. Right, Professor Kingsland.
Okay, we've got quite a few here. I'm 28 and have been trying to conceive for nearly 3 years, waiting to be referred to you very soon, hopefully. My AMH level is 13.6, but I never thought it would be that low, considering I've always had regular periods. Should I be worried? Well, AMH stands for anti-Müllerian hormone. It's a hormone that's secreted by the little cells that surround an egg. And the more AMH you've got, the more eggs you've got. It doesn't tell you about the quality of the eggs. Your age will tell you more about the quality, and your lifestyle, your weight, whether you smoke or not. So there are a lot of lifestyle factors will tell you about the quality, age being the most important one. But this is a quantitative number. AMH of 13.6 at 28, I'm not worried about that. That's normal. Being 28 and having an AMH of 13.6 is probably better than having a higher AMH and being 36. So to have because age is a very important factor. So, you know, I wouldn't be worried about that. That at the age of 38 is not bad at all. What we need to know, though, is why is it that you're not why you're not conceiving after 3 years. So the basic tests will give us an idea of what your egg reserve is, what your pelvis is like, and what your partner's sperm is like. Those three are very important tests. But then, of course, if you come to care and you do end up having IVF, that will not only tell us an awful lot about what is happening with your fertility, but it's also therapeutic as well, because as Ali said, we can create embryos, and then if the embryos are healthy and morphologically good, then we can replace them one at a time into your uterus, and that will give you the best chance of achieving a pregnancy. So don't worry, get to care as soon as you can. What tests can be carried out for recurrent implantation failure, please? Lots of tests. So we have a group in care, as Alison mentioned. We're a big group. We have 24 clinics and 14 laboratories throughout the UK with a staff of over 400 who are all dedicated to helping couples and single people achieve a family. So we talk together, we can interact together, and we have groups such as our recurrent implantation group, for example, that meet regularly and discuss what we need to do with special cases or what tests are best to help us to elucidate a diagnosis for you. Recurrent implantation, there are many tests, far too many to go into specifics. However, what we would do is to give an idea of to you as an individual as what is most important, or what tests are most important to help you to achieve a pregnancy or a healthy ongoing pregnancy. Your local care clinic will be able to help you with that. And as I say, if they need help, there are many other experts in our group that can help you. Can care look at NK cells? NK cells stand for natural killer cells, and they have been implicated in some cases in causing failure of implantation. It's a contentious subject. It's not right for everybody, and some people would refute the importance of NK cells. It's not a scientifically proven beyond doubt, but in some cases it might be helpful. We do have again experts in NK cells, and they will tell you, they will advise you what is best for you, and it's certainly not good for everybody, but in some circumstances it may be beneficial to test your NK cells. I'm 44 with unexplained infertility. Is there anything I can do to improve my egg quality chances? Well, actually, what you have to remember is at the age of 44, your eggs are 44 years old, and even if you may not look 44, unfortunately, your eggs will be. And so at the age of 44, there's no such thing as unexplained infertility. We would call it age-related infertility. And although your chances are not zero, they are lower than you would expect for a 34-year-old, for example. So at 44, if you want to try for a family, it's important you get very good advice as quickly as possible, because for you at that end of your reproductive maturity, you need advice quickly because time is running out. Same-sex couples, should we try IUI or is IVF usually better? Well, it's a choice. IUI is inter-uterine insemination, so it's female same-sex couples usually we're referring to. Inter-uterine insemination, when we get donor sperm and introduce it into the uterus at the most fertile time in the female partner's reproductive cycle. The pregnancy rate per cycle is about 8 to 10% per insemination. Now, if you were to take that a stage further and actually take your eggs out and fertilize them in a test tube with sperm and create embryos, if those embryos survive and grow in Alison's very clever care machine, then your pregnancy rate could be as high as 50% for every embryo that is transferred. However, for most people, IVF is far more expensive. And so it's a balancing act for the benefits of IUI IVF against the downside of how much it's going to cost. So it's important that you know before you start any treatment exactly what my chances are of success and how much that success is going to cost, so that before you embark on your fertility treatment, you have a clear idea about what's going to happen to you, what is best for you, how much it's going to cost you, and what are your chances, so that you can make an informed decision as to whether IUI is better or IVF is better for you. But in any case, it's whatever treatment is advocated, what is best for you as an individual.
Great, that's good. We've got a question on chemical pregnancies, Charles. So what's your advice for a couple who've had numerous chemical pregnancies?
Well, a chemical pregnancy is what we define as where you get a positive pregnancy test, but you don't have a clinical pregnancy. So a clinical pregnancy is where we see on ultrasound a fetus, a baby with a beating fetal heart. That is a clinical pregnancy. Once you get to a clinical pregnancy, then there's over a 90% chance that you will deliver a healthy baby. A chemical pregnancy is where an embryo is implanted and it has started secreting pregnancy hormone, but it's not reached the stage of a clinical pregnancy. And some cases, sadly, get to clinical pregnancy where implantation has taken place, but don't reach a clinical pregnancy. And there are many reasons for that, but the commonest reason, by far and away the commonest reason, is that the embryo is genetically abnormal. Depending on your age, maybe over 75% of embryos are genetically abnormal. When you reach 40, the age of 40, 75% of all the embryos that are created, not only in the laboratory, but naturally, are genetically abnormal. If you're 20, 25, 30, it's 50%, but it's still high. Humans create a lot of abnormal embryos, and that's why we don't get pregnant every month, or we have miscarriages. Over 90% of all miscarriages in the first 12 weeks of pregnancy are genetically abnormal. So I would say for you that a chemical pregnancy is probably in more likelihood due to the fact that your uterus is wanting to grow a baby, but the embryo is just not of sufficient quality. And when you have a chemical pregnancy, although that's very sad that it's not carrying on, sometimes you can be cautiously optimistic that your uterus is actually growing an embryo, wanting to implant an embryo. So it's sort of a test that your uterus is implanting. It's just that the embryo might be a bit deficient. And your doctor, when this happens, can help in all manner of means to try and get to the bottom of why the embryo is abnormal, or maybe it is under less common circumstances that your uterus is just not growing a normal embryo. That's far less common. But when you do have a chemical pregnancy, there are a lot of things that we can test and do and hopefully improve the chance so that you get onto clinical pregnancy with the beating fetal heart and then go on to a live birth, which at the end of the day is what we want.
Yeah, and I think it's important to say that we have this multidisciplinary team. So we work together, and when we're faced with a situation like that, we've got the right questions and we know how to find the answers, and we've got various different solutions. So every treatment's tailored. So even in the lab, for a case where there's a report of recurrent miscarriage or recurrent implantation failure, the patients had lots of embryo transfers but never any implantation. We have a specialised culture medium that we wouldn't use for everybody, but in those cases it's actually really effective. Lots of data and studies have gone into this, and so that's another thing that we can.
And I think that you've hit an important point, Alison. It's individualized treatment. You can generalize to a certain extent, and social media is classically, general. But what we need to know is what's best for you as an individual, and that's where the multidisciplinary expertise from not only in the clinic but throughout the care group can help to find out what is best for you to give you the best chance of a live birth and a family.
Right. Well, I think we should go on to the next phase of the evening's event. So we've got a short video. It's been prepared by Shah. So she's our new patient inquiry team leader, and she's going to tell us how to get started with care and how we support patients through their treatment. And then we've got Dave, who's Care's CEO, and he's going to briefly talk about life at Care and our dedication to supporting our patients. So, and then I'll call you back on. Thank you, Charles. So we'll get this next. And this one, Shah and Dave. Here we go.
I'm Shah, and I manage Care's new patient inquiry team. We're here to make it easy for you to take your very first step in your fertility journey. We completely understand how nervous and excited you might be when you contact us. This is the start of a life-changing process and hopefully the beginning of an amazing future as a family. So it's really important that we give you all the information you need. That way, we can help you to feel much more comfortable and confident with your treatment. Whatever you need to talk about, I want to reassure you that no question is silly or trivial. We appreciate that there might be a lot to take in at first, but don't worry, we'll send you a clear information pack about the treatments you're interested in, and we're always here for any follow-up queries. My team also manage inquiries about Care Pay, our range of funding packages which are exclusive to Care fertility patients. When you're ready, we can book you a virtual consultation with a specialist fertility doctor from your local care clinic. So, if you want more information, have a question, or wish to book an appointment, call my team. We want you to know that we are here for you at every stage of your fertility journey. We say that our patients become part of our Care family, and it's true. We care deeply about you and your future, and our teams are here to make sure you have all the support you need.
The reason why we chose Care was just, one, the care that they give you, the aftercare that they have available to you, and the fact that they offer different forms of treatment, and they listen to you. One thing that I've identified and what I've noticed when speaking to other people that I've met within the infertility community is there's a lot of clinics out there that don't necessarily listen to you as the patient. It was kind of a one size fits all, but with Care that didn't seem to be the case at all. They took everything into consideration, they listened to your concerns, they listened to you as a person, and they put a package and a process in place that will help you, and fingers crossed, will give you that positive result at the end of it. So without a shadow of a doubt, if I had to go through it again, I would definitely go back to Care.
Oh, the support at Care was brilliant, yeah. I mean, the nurses were brilliant for us. You feel so
looked after,
cared by the whole team. We felt that they did care, and it wasn't just for them getting something out of it. It was actually that
ongoing support.
Yeah, and they wanted it to work for us.
Care Fertility started over 20 years ago with one clinic and the goal of helping patients achieve their dream of family through truly personal care and the most scientifically advanced fertility treatments. We've grown from that one clinic. We now have clinics across the UK, and many people have become part of our Care family with over 50,000 Care babies in the world. But one thing has and always will remain the same. We care for each and every patient. We care about your dreams of having a baby, and we put our heart and soul into every aspect of what Care can offer you. To provide you with the best care possible and to give you your best chance of success in treatment, we look to our own Care family. From our consultants, embryologists and nurses to our admin teams and specialist fertility counsellors, we've also put a lot of thought into how we improve each and every step of your journey, which will no doubt begin with lots of questions. We know that thinking about starting IVF can be daunting for some, and that's why our Care patient services and support teams will always be there for you whenever you have a question, need advice, or simply want someone to talk to, so that you feel completely confident and in control of your fertility options. So yes, we have grown and developed over the years, but care and empathy are always at the heart of who we are. We are passionate about changing lives and creating futures, and I hope that this shines through in everything we do and everyone you meet at all of our clinics. We don't just care, we are Care.
There we are. So we've got time for a few more questions before we tie up. So hopefully Charles will be back any minute. So there's so many questions this evening. It's but I can see that on the questions tab, lots of them are being answered as we go along by the experienced team in the background, which is great. Right, so should we talk about varicoceles? There's a question here, Charles. So,
Yep.
The husband had a grade 3 varicocele. It was missed by the GP 10 years ago and has been there ever since. The semen analysis came back low. Have we got any experience of IVF and ICSI when there's a varicocele?
Yeah. So a varicocele is a varicose vein in the testicle, and it's just a manifestation of us walking upright. You know, sometimes blood sort of stagnates in blood vessels lower down your body, and then the blood vessel swells, and you get a pooling of blood, or like in your varicose veins. So it's just a varicose vein in your testicle. And the major downside to varicoceles is that they contain blood, and blood is warm, and sperm do not necessarily like to be too warm because they don't swim very well. That's why why testicles are outside the body, because sperm function and development is best performed in the cool. That's why we advocate anybody trying for a family or having difficulty to wear cool boxer shorts, have cool baths, keep your testicles cool, basically. So if a varicocele is present, we used to routinely think that varicoceles caused low sperm counts by virtue of heating up the testicles. Now, that can be the case, and often you will be advised to have the varicocele removed, particularly if it's symptomatic. However, there is some recent data and recent scientific evidence to suggest that removing varicoceles, asymptomatic varicoceles that are not necessarily causing any pain or discomfort, doesn't actually improve your sperm count. So again, it's an important decision to have with your surgeon or your urologist or your gynecologist, for example, as to whether it is beneficial, if you have a varicocele, to have it removed, or just keep it in place and carry on with other forms of treatment. Again, it's an individualized story, and it's not, you can't generalize for everybody. But I would say that if a varicocele has been present for 10 years and it has not caused any symptoms of pain or dragging sensation, then on balance, it may not be beneficial to have that varicocele removed. What I would do is probably live with it and get another opinion as to if there's anything else that we could do other than remove that varicocele. Because what we have to remember is it is a surgical procedure, and although it's relatively minor, you know, it's not without risk. You've got the anesthetic risk and all those sort of things. So there's a risk-benefit analysis. But 10 years, that's stretching it. That's a long time. And whether it'll be any benefit to remove it, I'm not so sure. But again, seek individual advice for you specifically.
Yeah, great. Should we just talk briefly about the pros and cons of fresh and frozen embryo transfer?
Okay, you start.
All right, I'll start. So, well, the most important thing, I think, is we have an option. In the past, embryo freezing wasn't particularly successful. It worked, but probably 80%, when I started, 80% of embryos survived a freeze-thaw process. Now, in our hands, with vitrification, 99% of embryos that we freeze survive successfully. So it's great to have that option, which means that if something isn't absolutely perfect, we're not particularly happy with the endometrium, or we think there's a risk of ovarian hyperstimulation syndrome, or lots of different reasons, we're waiting for a genetic testing result, we can very confidently freeze embryos and then wait and check the endometrium, check the situation, and thaw it out when the time is right. So it's absolutely great that we've got flexibility. And in terms of implantation rates, we really don't see a difference between fresh and frozen anymore. So it's phenomenal, really.
I'm a big fan of frozen embryo transfers. 80% of all embryos that are created in the United States are actually frozen now, and because of the relatively poor success rates of frozen embryos going back many years, what we used to do was to try and get the embryos back fresh because of the lower chances. And of course, the best treatment for IVF is to stimulate the ovaries, collect as many eggs as we safely can, fertilize them, and then put one back and freeze the rest. Now, sometimes the hormones that we give you to stimulate your ovaries to collect eggs, because it's eggs that make babies, we need eggs, not just one, to try and to give you a better chance of success. We need more than one egg if we possibly can. Those hormones may be good for stimulating growth in eggs, but they may not be good for the lining of the uterus. Similarly, for anybody who's gone through IVF, the hormone injections can give you side effects that can make you, feel a little bit under the weather, a bit bloated, and in extreme cases can cause hyperstimulation and swelling, which Alison alluded to. So sometimes you may not feel in the best position to have a fresh embryo, in which case it's better to freeze them. If you freeze them, you can then go away. We can make a little bank with your name on the bank with all your little frozen embryos. You can go away and recover, take some time out, then come back and control the environment in which we're putting the embryo back. So we thaw the embryo out, and as Alison says, there's a 98% chance of that embryo thawing very healthily, and put it into the perfect environment, a well stimulated, thick endometrium that is at the right time for the growth of the embryo. So there's a lock and key mechanism. And we in Liverpool, for example, we're big fans of frozen embryos, as are many clinics. But again, and I've stressed this before, it depends on the individual as to whether you have a fresh embryo or a frozen one. What's great, of course, if you get more than one frozen embryo and you've got a whole bank, that bank can be then frozen in time, so you can the embryos don't deteriorate, and you can have maybe a whole family frozen. Who knows?
Great. Well, should we do one more question before we've got the final video? Just talk about polycystic ovaries and is egg quality, what is it? And is egg quality likely to be lower?
Well, polycystic ovaries is a syndrome, and a syndrome in medicine is a disorder which has a spectrum of symptoms from very mild to very severe. Most polycystic ovaries, poly means lots of, cystic, lots of cysts in the ovaries, and these cysts contain eggs of variable quality. It can be, as I say, it can be very mild, it can be very severe, but generally speaking, the issue with fertility in polycystic ovaries is that the female has lots and lots of eggs that have not necessarily been ovulated, are at varying developmental stages in their ovary. And so often we see women with polycystic ovaries who have lots of eggs, but of variable quality. So there are many treatments available. We have world experts in the field of polycystic ovaries working in care now, who can individualize your treatment from very mild, just weight reduction, dietary advice, to simple ovulation induction agents, right the way through to IVF. But there, with polycystic ovaries, there is a treatment available for you. And the thing you have to remember about polycystic ovaries, it's very common. Up to 40-50% of women who present at a fertility clinic will have some degree of the polycystic ovarian syndrome, from very mild to very severe, and we're able to deal with them all.
Yeah, and do you recommend mild stimulation for these patients, or not necessarily?
Yeah. So the issue that we have with polycystic ovarian syndrome, if you reach the stage of IVF, is that we have to be careful to titrate the dose of stimulation with the number of eggs we want, because often women only need just a tickle, a small amount of stimulation to grow and mature a lot of eggs. And what we don't want, we want enough eggs, but we don't want too many. So what we have to be very careful about is not to overstimulate those ovaries, because women with polycystic ovaries do have quite sensitive ovaries. So we have to be sensitive to the fact that they will need extra special monitoring.
Brilliant. Right, well, I think that's about enough questions for now. We're coming towards the end of the event, but we'd like to leave everyone with a few final words. Another nice video all about care and how you can get in touch with us and book a consultation. So don't forget, we'll get back to you all with answers to any questions that we will not be able to handle tonight, and the inquiry team are there till 8 o'clock this evening to take calls. So with that, thank you very much, Charles.
Thank you, Alison. Goodbye, everybody. Good luck.
1 in 6 people need help to grow their family. You're not alone. And our care family will do everything we can to help your dream of family come true. There are over 50,000 care babies in the world today. And behind this success is our promise to make more heartfelt dreams of family become reality by ensuring our care goes into everything we do for all our patients every single day. You will receive truly individualised treatment, a patient-centric approach with empathy at its heart. We understand how nervous and excited you might be about getting started, but you can be assured of kindness, empathy, and all the information you need from our new patient inquiry team. We are all here to make it easy for you to take your very first step in your fertility journey. Call our team on 0800 564 2270 to learn more and book an appointment. We don't just care, we are care.
And with that, thank you very much once again for joining us. I hope you found it informative. We'd really love to hear your feedback. With that, have a good evening. Thank you.